I would request our next speaker. First, I would just introduce him. It's none other than Dr. Anilkumar V. Designed his own K-wire jig for pinning for distal radius fractures. Has successful presentations at various international forums in Singapore, USA, and South Africa. And today, sir is with us to talk about a very interesting topic about supracondylar humerus fractures in pediatrics with his close reduction and percutaneous pinning. Over to you, sir.
Good evening, you all, sir. Sorry for the inconvenience. I am Dr. Anilkumar from Kerala, presenting an innovative method of CRPP for type 3 and 4 supracondylar fractures of the humerus in children. Supracondylar fracture of the humerus is one of the most common injuries in pediatrics, and accounting of 16% of all pediatric fractures and 60% of all pediatric elbow fractures. I am not going to the details of the classifications, and also regarding the treatment modalities also I am not going. I am presenting the type 3 and 4 fractures by my own technique of CRPP. This is the demography. CRPP done in 40 cases of type 3 and 4 during 2017 to 2020. Age group is 1.5 to 16 years. The first step of this CRPP is a close reduction, which is done in 3 steps, and the distraction of the fracture fragment done by traction countertraction technique with an assistant in the line of the humerus in a slightly flexed position of the elbow to disengage the proximal fragment from the muscle and thereby protecting the iatrogenic neurovascular injuries. This can avoid the complications of the conventional joystick method of close reduction through the medial epicondyle and also the milking maneuver. The compression of the fracture may be required in intercondylar extension type of fractures. After primary clinical judgment of the reduction is done, and the clinical judgment was done by the orientation of the imaginary triangle created by the olecranon with respect to the epicondyles. Imaging was not done at this stage because it may lead to the loss of reduction. You can see this video for the rotation corrections. The fine correction can be done at this stage with the distracted position itself. That's the main advantage of this. And we can proceed for the spinning technique. First step of the percutaneous spinning was done with the 2 caveats of 1.6 mm in crossed manner from the medial epicondyle and second from the lateral epicondyle, sparing the olecranon fossa without any skin incision. If the fracture has a bicondylar extension, it should be fixed first with a transverse cavea from the medial epicondyle below the olecranon fossa by maintaining the compression of the distal fragments with the hand. We can see the picture of the orientation of the wires from the figure. The percutaneous spinning of the second set for confirmation of the cavea, the position, the imaging was done with ZIA and the projecting end of the cavea shortened for smooth introduction of the second set of wires. The third wire from the lateral epicondyle and also the fourth wire from the medial epicondyle. The final confirmation of the cavea position were checked. After confirmation of the position, the cavea is shortened and placed into the subcutaneous plane. The end of the cavea is bent and placed in the subcutaneous plane with the cavea bender and also wire cutter. We can see the bending of the caveas and cutting short by giving deep pressure towards the bone. This is the end of the wire is placed into the subcutaneous plane by pulling with the thumb forceps. So that there is nothing will be seen outside, and a POP slab is applied in 90 degrees of flexion. Regarding the postoperative protocol, patient is discharged on the second day and reviewed after 1 week for check X-ray, and third week the plaster is removed and check X-ray is taken, and active elbow exercises by the patient for 1 more week, and K-wire is removed at 4 weeks, and review after 6 weeks, 12 weeks, and thereafter 6 months for 3 years. These are the sample cases, the variety of cases of type 3 and 4. That is, these are the 11 total different cases which I have done during the 2017 to 2020. This is a 10-year-old boy with a severely comminuted supracondylar intercondylar fracture with the extension to the diaphysis, and which has taken the video at 6 months and X-rays of both upper limb for comparison of the results of the cosmetic as well as functional results can be assessed from here. This is an 11-year-old boy with a supracondylar fracture of the left elbow, 3 years after taken the video, and also the elbow X-rays of both upper limbs. You can see the preoperative X-ray and postoperative X-ray also there. This is an 8-year-old boy with a supracondylar fracture of the left elbow at 4 years. You can see the cosmetic as well as functional results from the video as well as from the X-rays of both upper limbs. This is an 11-year-old boy with a supracondylar fracture of the right elbow at 1 year. You can see this preoperative X-ray, postoperative X-ray, and also X-rays taken at 1 year of both elbows for comparison. This is an 8-year-old girl with a supracondylar fracture of the left elbow at 1 year. You can see the preoperative X-ray, postoperative X-ray, and the X-ray taken of both elbows at 1 year. From the video and X-rays, you can assess the clinical, cosmetic, and functional results. This is a 12-year-old boy with a supracondylar fracture, left elbow, the 3 years after the taken the video, and the preoperative X-ray, postoperative X-ray, as well as the X-rays of both elbows are shown for result comparison. This is a 7-year-old boy with a supracondylar fracture, right elbow, the video and X-rays taken after 9 months, and preoperative X-ray and postoperative X-ray and figures are also shown there. And this is a 6-year-old girl with a supracondylar fracture of the right elbow, 9 months after the injury. You can see the preoperative X-ray, postoperative X-ray, and also the X-ray taken at 9 months for the evaluating the cosmetic as well as functional results. This is a 5-year-old girl with a technically compound supracondylar fracture elbow, 4 years after taken, and this was the one case in which the varus deformity was evolved. That is because of that compound nature. I was afraid of doing the deep close reduction in a superficial manner. That's why it was happened, but the full range of motion was achieved. You can see this range of motion as well as the X-rays. This is a 7-year-old girl with a flexion type of supracondylar fracture of the right elbow. And you can see the pre-op X-ray and post-op X-ray here. I have used only 2 cavities because the fracture is very close to the epiphysis and there is no space for the introduction of the second set of wires. And so, because of its crossed nature of the spinning, it was very well worked and good result was obtained and full range of motion was achieved in 3 months. This was an 11-year-old boy with a supracondylar fracture elbow at 1 year. Here I have used only 3 wires because there was a bad skin in the medial side for the introduction of the second wire from the medial epicondyle. The very good result was obtained. These are the results of the 40 cases. 38 cases have excellent cosmetic outcome and 1 had good result and 1 has fair result. Excellent functional factors in all cases at 6 months, and radiological measurements of the carrying angle and angle of movement between the injured limb and normal limb were showed equal or 0 to 5 degrees in 38 cases, and 5 to 10 degrees change in one case and 11 degree in one case. And Mayo elbow performance score is also maximum score achieved at 6 months. These are my complications. One case had a varus deviation of 11 degrees. 2 cases had a superficial skin infection subsided with antibiotic therapy, and pin loosening happened in 1 or 2 cavities. But because of the 4 number of cavities, which was not affected in the stability of the fixations. No major complications like neurological, vascular, or adverse stiffness. No compartmental syndrome were encountered pre or post-operatively. No patients required reoperations. Regarding the discussions, the timing of the treatment, and also the positioning of the cavities, there are controversy in the literature. We can discuss it here. These are the results. In conclusion, the modified method of CRPP can be successfully applied in the treatment of type 3 and type 4 supracondylar fractures or humerus in children for getting a superior result, avoiding the usual complications. Thank you. Thank you, sir.
Thank you, sir. Yeah, Dr. Gandhi, any questions from your end?
Yes, sir. Dr. Saab, very good presentation, very informative and very encouraging also. Now, one thing which I have always been surprised is how many times you are worried about the spike piercing through the anterior muscle mass and possibly hurting the brachial plexus, brachial artery. How
Yes,
commonly you encountered that?
Sir, previously I was doing with this milking technique and also this joystick maneuvers, but this technique of distraction, distraction means a very good distraction, that is disengaging the proximal fragment from the muscle mass by action in a slightly flexion, 20-degree flexion of the elbow I am giving. And also that the distal fragment is holded by one of my hands and it is flexing, and so that because of that muscle, the proximal fragment will be disengaged easily from there and we can reduce it also. Till the introduction of the wires, I will keep this traction without losing. That is why I am not checking these positions also. Because of it may, if we are going for a checking, there may be a fatigue of the hands of the assistants or my hand, and it's, the end of the reduction may be lost, or the spike may be gone for into the this neuromuscular bundle. In my experience, this is the best technique for avoiding these neuromuscular complications, iatrogenic neuromuscular complications by the surgeon.
Good. And another question is that when you are maintaining the traction, you mentioned about it, and you told that from olecranon fossa, next to olecranon fossa, you enter. Now, there are times in a flexed position, it is not easy to isolate the median nerve when you are going from a median side. So you go there or you go at the epicondylar level?
Sir, for the even if there is edema, that is in the late presentation cases also, we can identify this ulnar nerve. Ulnar nerve, because this middle epicondyle, we can palpate it by giving a deep pressure with the thumb for 1 minute. We can displace the edema from that area, and after that we can feel that ulnar nerve, and which can be pushed backwards.
Okay.
And till the completion of the cavities from the middle side, that nerve will be in the hand of in my hand, that is with the thumb or index finger, depending upon the side, left or right.
You use a plain KVS or a threaded KVS?
Plain cavities, sir. Plain cavities.
Okay.
So that we can without imaging, I am doing this thing. So I am feeling this the penetration of the cavity through this cortex, medullary cavity, and the opposite cortex from the resistance which I felt in the drill. That's why I am using this smooth cavities for this case.
And other thing is that I have seen your lower radius presentation wherein you use a small mini X-fix for keeping the fixation while you are doing the fixation. Do you use any such device or you do free hand?
No, sir. It is only free hands. Only one assistant will be with me till the completion of the first set of wires. After completion, Pardon, sir?
Yeah, please go ahead. Sorry, sir.
Because I am putting this wire from the medial side is the first wire. That is because that medial epicondyle we can feel and locate it very correctly. So that from the lateral side it is very difficult for the younger child to this feeling of from the lateral side because that area.
Mm-hmm.
But here the point of entry can be pinpointed from the medial side, and also once we are pushing back the ulnar nerve. We can pinpoint the location, and also after that pinning, that the fracture will be stabilized. There won't be much rotations while fixing this medial side. If you are going for this lateral side first, then we have to rotate it internally. That may rotate. There may be a chance of rotation, internal rotation of the distal fragment before doing that fixation. During that fixation. So I am doing from the medial side is the first, and the fracture will be stabilized. Then there won't be any movement at all. And also the maintaining the distraction till the first set of wires are inserted.
How many wires you generally put? The common numbers like 3, 4, 5, or it is as much as required?
Yeah.
Depends
So
on the...
generally I am using 4 wires. That is 2 from lateral side and 2 from medial side. Depending upon the local conditions, I may reduce it from the medial side. It is if I cannot put 2 wires, I will restrict it for 1. From the lateral side, it is very easy. We can use you can use 2 wires, and also in one of my cases, it was lower third humerus is also fractured. It's a separate butterfly piece was there. I was fixed with the additional K-wires from that side also. That's the first case.
Have you ever faced epiphyseal injuries later on, long term, when
No,
because you're crossing the epiphysis on both the sides with total 4 wires?
Yeah.
So like there are a lot of studies which does mention that you should not pass through the epiphysis.
Sir, that's a thing. Usually, if the fracture is a little bit above, I will spare this epiphysis. I will put it as much as possible through the lateral side, through this metaphysis I am putting. And if it is not possible, I will do it. One of the cases I have shown you that's a flexion type of injury. I have put only 2 wires. That is because the fracture is very close to the epiphysis and there is no space for introduction of the second set of wires. So I have restricted for 2 wires in that case that I have shown there.
Now your take on one thing, say 2, 3, 4 wires from one side, only lateral side, because a lot of people recommend that put multiple wires from one side rather than going on the medial side to safeguard the medial ulnar nerve. What's your opinion on that?
Sir, the literature also, the more supporters are like that. That is, I am against that because that will reduce the results. That's a complications. That the rotational complications are more chance when if you are putting either 3 or 4 from the lateral side itself. Otherwise, if you are putting only 2 wires, that is in a crossed manner. That means it will be stable. That is number 1, the stable fixation. Number 2, after 3 weeks, if you need, we can remove it at 2 weeks also. After 2 weeks or 3 weeks, we can remove the plaster slab and with the K-wire, which is in the subcutaneous plate, so that there is no hindrance of the movements also. The patient can do the personal active exercise and there won't be any stiffness, and by the end of 3 months, everything will be fine. In 95% of my cases, it's like that, sir.
Very good presentation, sir. Thank you for sharing.
Thank you, sir.
Thank you.